Mangkut, sino ba yan? Mangkut, sino ba yan? Mangkut, sino ba yan?
Ay, magandang hapon. Diyan ka na pala.
Magandang hapon ho.
Hello, good afternoon.
Good afternoon po, Dr. Ike.
Good afternoon, boss. Kuya Alex, good afternoon.
Hoy, kumusta?
Okay naman. Ito, ang daming webinar, no?
may nagpa-set ako ng meeting kay Che sa Monday.
Oh.
Ka?
Anong oras? Anong oras nga ba yun? Alam ko meron eh. Oo.
Alas 5.
Oh, sige. Oo.
Oo.
Nandito sa calendar ko.
Oo, sa yung accreditation guidelines ng
Yes, oo, tama nandito. Tama, 5 p.m.
Oo, bale with your permission, pinadala ko rin yung ginawa nyo para sa advance guidelines para sa advanced fellowship, baka may mapipick up tayo doon para at
Oo.
least nabasa na nung committee members. Hindi, para mabilis ang meeting.
Ang gagaling ng committee members mo, nakita ko mga veterano na sa accreditation. Di ba? Mga sanay na.
Nandun si Dale. Nandun si
Oo.
Dale. Kaklase niya yata si Dale, di ba?
Kabatch ko sa internship. Oo.
Oo. Ayun.
Sabi ko, nakita ko mga ano na to, experience accreditation.
Si Dennis, ang gusto niya, meron tiga Cebu, meron tiga Davao, para kung hindi man mabibisita, ay di, andun sila.
Oo.
Maghanap pa yata ng tiga Northern Luzon.
Northern Luzon, oo.
Oh.
Maganda yan. Maganda composition ng accreditation. Nakita ko.
Kailan ang ating board meeting?
Ano na?
Kailan ang ating board meeting?
Sinet natin ng first week ng October eh. In-announce ko nung ulit. Tagkahating na sabi ko dito. I think in-announce natin nun eh. Saan ba nilagay yun? I-verify ko lang kay wala hindi ko makita. Pero verify ko kay kung hindi first week, second week ng October. Check ko na lang. Balitaan kita. Hanapin ko. Pero accreditation meetings Monday, 5 p.m. Marami nag-enroll doon sa ating workshop. Basic methodology course yung ginawa ni Imon.
Oo,
mga residente niya rin.
Oo.
Galing. Ganda. Galing nila magturo ng methodology. Yung mga faculty, si Dr. Lido, lahat sila. Magagaling. 15
Bali
years
ang attendees natin ngayon ay mga residents, plus interns, at saka yung mga clerks namin. May clerks na kami dito, base hospital na ito ng ng Adventist.
Oh, ganun ba? Oh, that's good.
Medical school,
Oh. Ang Adventist Medical School is located in
parang sa Cavite. Tama ba ako? Mga clerks? Sa Cavite
Silang,
yung inyong
Cavite.
Silang Cavite. Okay. And dyan sila nagra-rotate for their internship, junior internship sa clerkship.
Clerkship. Oh.
Clerkship.
But yung start nung kanilang yung clinical na sila dito. Nagro-rotate na.
Galing. Okay yan. Maraming clinical material. Ganda ng music. Happy music. Nakaka-relax.
Hello, sir.
Hi, Sir Romero.
Hi, sir. Good afternoon po.
Good afternoon. Kayo moderator.
Yes, sir.
Okay, very
Mga
good.
oras tayo. Pwede na ba?
Eunice, can we start na the program?
Yes, tayo. Jackson.
Okay, please.
Pleasant afternoon to everyone. We would like to welcome you all for this lecture regarding fluorescence guided surgery. And this event is made possible in partnership with Transmedic and Stryker. I would like to call on one of the sponsors of this activity, the country manager of Transmedic, Ms. Vanessa Amabagan, to give us a short introductory message.
Hello, good afternoon. Thank you, Dr. Romero, for the introduction. Magandang hapon po sa inyong lahat. Good afternoon, Dr. Mendoza, Dr. Palines, and everybody. So it is with great pleasure and honor to be part of the Batangas Medical Center Surgery Month event. On behalf of Trent Medic Philippines and Stryker, we would like to express our gratitude to the Department of Surgery headed by Dr. Alejandro Palines for giving us the opportunity to talk and share about OR integration and fluorescence imaging for today's session. So we hope that you could stay until the end of the session to learn more about our OR integration technology from Stryker and why we are superior compared to other brands. We look forward for more collaboration and hopefully a long-term partnership with Batangas Medical Center. Thank you, everyone. Stay safe and be well.
Thank you, Ms. Amabagan. Now, before we start this activity, let us all remember that we are in the most holy presence of God. In the name of the Father, the Son, and the Holy Spirit. God of infinite love and mercy, we call upon you in this time of illness and challenge. Grant healing and comfort to the sick and strength to all caregivers. Aid our perseverance and lessen our distress. May we put our trust completely in you. Through Christ our Lord. Amen. So let us all welcome our chairman from the Department of Surgery, Dr. Alejandro M. Palines, to give us an opening remark.
Yeah, good afternoon, everyone, and welcome to our 20th activity for our Surgery Month celebration. Let me take this opportunity to again thank Dr. Ike Mendoza, our current Palace President. And Dr. Mendoza has been very helpful to our department. He has been here a couple of times, and the last activity that we had was the zero bile duct injury lecture series, where Dr. Mendoza is the principal advocate, and he brought along a team of lecturers from our palace board, and they even demonstrated the use of ICG in our live surgery. And for that, we would like also to thank Transmedic for their support. ICG is very important because it makes the job of the surgeon easy. It will give you information regarding if the bowel anastomosis is viable. It will also let you know if in your thyroidectomies, if your parathyroid is viable also. And when you encounter difficulty in doing cholecystectomy, whether open or laparoscopic, ICG will provide you the roadmap so that you can avoid injuring the common bile duct. So this is again a treat for all of us. Dito pa naman in this part of the country, in Batangas, I do not know of any hospital who has capability of doing the ICG. Pag nag-ICG kami dito, ay we borrow the towers from kung sino man magpapahiram just for demo. Pero yung mismong to do it routinely ay wala pa talaga. So I hope later on we will have our own capability of performing this imaging. So again, welcome everyone, and good afternoon.
Thank you for that message, Dr. Palines. And now may we call on our moderator for this event from the section of hepatobiliary surgery, Dr. Raymond Joseph Romero.
Hello, good afternoon, everyone. Again, welcome to our series of lectures in celebration also of our surgery month and the 35 years anniversary of the Department of Surgery of the Batangas Medical Center. So we brought you another topic, which is the fluorescence guided surgery, and to be followed by the Stryker iSuit integrated operating room setup. So for our first distinguished speaker, he is one of the best minimally invasive surgeon in the country, the chief of the minimally invasive surgery and associate professor of surgery of the University of the East, Ramon Magsaysay Memorial Medical Center, and the program director of the minimally invasive surgery fellowship program of the Asian Hospital and Medical Center, and currently the president of the Philippine Association of Laparoscopic and Endoscopic Surgeon. So let us welcome Dr. Miguel C. Mendoza. Sir, you can share your screen now for your presentation. So we remind everyone to please mute their mic while Dr. Mendoza is doing lecture. Thank you. And if you have questions, just type your question at the chat box. So later we will cater your questions. Thank you.
Maraming salamat, Dr. Romero. Thank you very much for that kind introduction. And magandang hapon po sa inyong lahat. No? And congratulations for your surgery month sa Department of Surgery sa Batangas Medical Center. Maraming salamat, Dr. Alex Palines, Chairman of the Department of Surgery of BAT-MC, who also is with the board of the Philippine Association of Laparoscopic and Endoscopic Surgeons and heads also the very important committees on the Committee on Bylaws and the Committee on Accreditation ng ating organization. And with Dr. Alex as chair of the Department of Surgery, together with his officers, and of course, Dr. Berberabe as a training officer, I'm sure you will be able to achieve yung objective nyo of getting an ICG capable equipment in your institution. It is really good for the clinicians as well as very good for the students to learn from. So maraming salamat, Dr. Alex, for inviting me. I would like also to extend my appreciation, of course, to Dr. Roy Berberabe, the training officer, as well as our good friend, Dr. Monchi Magnaye, and all the consultant staff of Batangas Medical Center. I really enjoy visiting your institution. Parating masaya, and these people are very, very accommodating and very, very hospitable. So maraming salamat ulit for the opportunity. At thank you rin sa ating Transmedic friends, Vanessa. Maraming salamat for inviting me, for always inviting me to speak on behalf of Stryker for certain important topics that we would like to share. And of course, Ana Ria Batan from Stryker. Maraming salamat for inviting me. For everyone, as you know, even before and during my training 20 years ago, I was already using Stryker equipment. It has been with me and I've been using it during the early days when it was still an analog and not digital or 4K as we have it now. And therefore, this brings me to this topic, which is about laparoscopic cholecystectomy. And we would like to focus on this because through the years, I've seen the development of the equipment in minimally invasive surgery to now that we're using ICG fluorescent imaging. So we will talk about this. And our objectives at the end of this lesson, or at the end of this lecture, for all our residents, our interns, our clerks, and for all of us would be, at the end of this lecture, we should be able to discuss the main cause of bile duct injury during lap chole, because we will focus on this particular topic. Describe the various options in preventing bile duct injury. How can we prevent it? And correlate it also with the use of ICG in our procedures. And also understand and explain, more importantly, the fundamental mechanism of ICG and its main role in laparoscopic cholecystectomy. So we will focus on laparoscopic cholecystectomy, gallbladder surgery, because this is the most common procedure being done. But of course, we know that ICG works for other procedures, those that were mentioned by Dr. Alex Palines, like parathyroids and adrenals and liver and many other organs that we encounter in general surgery. So why is this very important lecture for me as far as sharing with everybody? Because we have an advocacy in PALES in the prevention of bile duct injury. And although there are many injuries that may happen, potentially happen, when we do a laparoscopic cholecystectomy procedure, we will focus primarily on bile duct injury because this is an injury that can be devastating really to the patient. In long term, and some patients may even need liver transplant because of repeated surgeries to repair the bile duct and repeated concomitant liver failure. So this is something we think is very important. One of the most feared complications in laparoscopic cholecystectomy is bile duct injury. And we know that laparoscopic cholecystectomy has been with us for the last 30 years or so. And we know also, based on literature, international data, that bile duct injury in lap chole has been nowadays placed at 0.4 to anywhere up to 0.8%. And looking at it, it is 2 times to 3 times higher than open cholecystectomy. Even if the injury rate is less than 1%, the sheer volume of procedures being done every year all over the world, you have a 0.4% or 0.8% bile duct injury rate, you're talking about of thousands of injuries a year. Okay, and therefore this is very, very important, and that is the advocacy of PALES, together with all the members of the board, to promote the prevention of bile duct injury in the country through education and training. And when you look at the paper done by Lawrence Wei et al. From the University of San Francisco in California, he found out that the most common cause of bile duct injury is not the technical skill of the surgeon. It is 97% due to visual perception illusion. Ibig sabihin, this simply means to say for our interns and our clerks and residents that the surgeon mistakes the bile duct as the cystic duct. Visual perception illusion. And it's only in 3% of cases where it is the technical skill that is the problem. Hence, we should find ways on how to prevent this from happening and identify the proper structures before we cut it, clip or cut it. And we also know that in the biliary tree, there are a lot of variations, anomalies, accessories that we have encountered in the past. But do we really see them? Do we really know them? Can we anticipate them? Or do we need some imaging procedures to help us identify these variations and anomalies? And I think the answer to this question is yes. Since we know that this area has the most number of variations and anomalies, no? Then we need some imaging procedure to guide us during our operation. And that is very, very important. And the classic laparoscopic injury is mistaking the common bile duct as the cystic duct. It may be because that the cystic duct is fused with the common hepatic duct because of fibrosis, and now you mistake the bile duct as the cystic duct. Or sometimes you see that you cannot dissect the triangle of Calot, and you end up with all sorts of injuries like transection of the common bile duct. So there are many factors that bring about to this occurrence. And if you look at these two videos, I hope you can see it, and it's fast, no? It's moving. The most common cause of bile duct injury is the misidentification of the common bile duct as the cystic duct. And the surgeon will swear that what he cut was the cystic duct. And this is because he perceived this as the cystic duct, but actually he is cutting the bile duct. And therefore, we want to prevent this from happening. And we go around the country giving lectures, live demonstrations, as well as together with the board of PALES, in order to educate our surgeons, especially our young surgeons, in how to prevent this from happening. So proper training is important, experience is important, patient selection is also very, very important. And we have to standardize already the curriculum as far as how to perform a safe laparoscopic cholecystectomy is concerned and know the fundamentals for it. So it would be easier for us to overcome the learning curve. So we should also be aware as surgeons, no, of the bailout maneuvers when we encounter a hostile environment when we do laparoscopic cholecystectomy. And we should also know when it is time to convert to open surgery. And here we have to set our ego aside and convert to open if we feel we have to convert. Timely conversion is the key. And if we decide to convert to open, preemptive conversion, that means before injury happens, is better than reactive conversion, which means that injury has happened and we decide to convert. So this is very important, timely conversion. And there is no shame in converting from lap cole to open cole because what we want is the safety of our patients. And therefore, in our advocacy, when we go around the country, we look at different pearls in preventing bile duct injury, and we teach this to our residents and our colleagues. No, first, identify the 5 landmarks. This is the clinical way of doing it. No, we'll go to the imaging later on. Identify the 5 landmarks. And what are the 5 landmarks? The right hepatic crease, first portion of duodenum, the pulsating hepatic artery, the common bile duct, and the infundibulocystic junction. Which means to say anything below the right hepatic crease, above the first portion of the duodenum, to the right of the pulsating artery, that is a hostile area. And stay away from that area because your bile duct is there. And we should also identify the critical view of safety as espoused by Strasbourg. You know? They advocated this even in the mid-80s in open cholecystectomy. And the critical view of safety means to say you have to see the cystic duct, cystic artery, and cystic plate, devoid of any fibrofatty tissue, both anterior view and posterior view. And you also have to be able to identify the cystic plate and dissect the cystic plate at least 1/3 of the entire posterior wall of the gallbladder. So that is the true critical view of safety. Because some would say a critical view of safety is just the cystic artery, cystic duct. Some would say critical view of safety is cystic artery, cystic duct, cystic plate. But you have to define it very well, free of fibrofatty tissue, and the cystic plate or the posterior wall of the gallbladder has been dissected at least 1/3 of its entire length. That is the real critical view of safety. Then we have to perform a bile duct injury timeout or a 0 BDI timeout, similar to the timeout we do before we start our surgery, as espoused by the World Health Organization. Ito, we encourage a 0 bile duct injury timeout. Ibig sabihin, before you clip and cut the bile duct, you go through a series of questions. And there is a template that was created by PALES and is being distributed to all training programs. And in that template, the nurse will ask you, have you identified the landmarks? And you answer yes. Have you identified the critical view of safety? You mention it and you point it to them. And next question asked is to the assistant, do you concur with the findings of the surgeon? The assistant says yes, then you are safe to clip and cut that cystic duct. The reason is the most common cause of bile duct injury is misidentification of the bile duct as the cystic duct. And if you misidentify this, it leads to bile duct injury and it leads to a patient who is biliary crippled. And when a patient is biliary crippled, he has multiple operations, liver failure ensues, liver transplant may follow. And studies have also shown that patients who had bile duct injury have a higher incidence of malignancy in the biliary. Okay, so that is something we have to consider. So there's thorough and judicious use of electrosurgery. We use IOC. We know how to perform a bailout options, which I'll show you later on, convert to open. And of course, the latest, using ICG to define the anatomy, which we will show you in the next few slides. So just to give you a quick view of how a laparoscopic cholecystectomy is performed and how we safely present this to our students, and for mostly for the benefit of our interns for today's lecture, as well as for our clerks, as well as for our residents. So identify the landmarks that I have mentioned: cystic hepatic crease, first portion of duodenum, pulsating hepatic artery, common bile duct, and the infundibulocystic junction. We dissect at the area of the infundibulocystic junction. That's where we start. We open the visceral peritoneum. We are not focused on isolating the cystic duct and cystic artery. You may use blunt dissection, stripping technique, electrosurgery, but make sure that you use the cautery in just short bursts of current. Okay, so just take down the visceral peritoneum. Nothing's being dissected at the area near the common bile duct. As you open that visceral peritoneum, you gain additional length from the bile duct area. The purpose is just to open up the cystic plate. And once the cystic plate is opened, you now are trying to identify the critical view of safety. And you're now dissecting the cystic duct and cystic artery. And you're isolating it now. And we're not going deep. We're just going superficially, just dissecting the visceral peritoneum. And we're staying above the right hepatic crease. We're staying away from the first portion of the duodenum. And we are staying away from the pulsating hepatic artery. And as you can see in this triangle of Calot, we have now isolated cystic duct, cystic artery, and cystic plate. This is the critical view of safety, devoid of fibrofatty tissue with the cystic plate dissected at least 1/3 of the entire length of the posterior wall of your gallbladder. In the posterior view, you see also the cystic duct, cystic artery, and cystic plate. And that is now called the doublet view. And after this, that is when you do your zero bile duct injury timeout. And when you know you're safe to clip after the zero BDI timeout, that is the only time that you decide to clip and cut. So in the event that you develop a hostile environment, let's say, for example, in patients wherein there is a thick gallbladder, acute on a chronic affair, and you cannot identify the critical view of safety, you cannot identify the landmarks very well, what do? Do we insist in doing what was taught to us? Dissect the critical view of safety? The answer is no. Make a judgment immediately. Abort that technique and proceed to a bailout maneuver. And in this bailout, this is what we call now a subtotal cholecystectomy, where we try to remove just the anterior wall of the gallbladder, making sure that we do not enter the triangle of Calot because it will be very dangerous when you enter that, and making sure that we take out all the contents in the gallbladder, and making sure that there is no stone left by doing either a cholangiogram, and making sure that we close that opening, which we do most of the time, but it may be left open and just put a drain. And here you can see a subtotal cholecystectomy using the fenestrating type technique. So you have the core out, you thicken gallbladder wall, just ligate that mucosa, no? And you have ligated the structure. You don't have to take the entire wall of the gallbladder, especially that wall that is attached to the liver, because you will bleed, or that wall that is attached to potentially the common bile duct and common hepatic duct. So you leave that wall behind, and that is your protective shield. So in the event of difficult anatomy in laparoscopic cholecystectomy, the gold standard is performing an intraop cholangiogram. And each and every resident should be familiar in performing an IOC when you do a lap chole. You should be comfortable in performing an IOC. And the success of an IOC is surgeon dependent. If you don't have the skill to do an IOC, you will not be able to perform this IOC successfully. So it is proven and useful in identifying the anatomy. It does not guarantee 100% prevention from bile duct injury, but it requires skills training, added personnel, specialized equipment. And one more thing, there is exposure of the entire team to radiation. And if one does not have a systematic or way of performing the IOC, and one does not have a C-arm in performing the IOC, and just using a portable X-ray, then it becomes time-consuming. Okay? But for the benefit of everybody's knowledge, IOC is the gold standard in identifying the biliary tree, especially for stones in the biliary tree nowadays. Now, is there a viable alternative in identifying the biliary tree during lap chole? The answer is fluorescent imaging using indocyanine green. So that is the main gist of this topic. So as you can see, we show the significance of injuries in laparoscopic cholecystectomy. We know the traditional way of identifying the biliary tree. We are now moving towards the modern approach in identifying the biliary anatomy to prevent bile duct injury or to mitigate the risk of bile duct injury. So what is indocyanine green? So indocyanine green, just as a background, is a fluorescent dye that was developed by Kodak in 1955. I don't even know if the generation now knows who Kodak is. No? Time namin ni Alex, alam namin to sino si Kodak. We use a lot of these films during the early days. It was approved for clinical use in 1956, itong indocyanine green, and after 10 years was used for angiography. In the 70s, the most common use of ICG was for retinal angiography, and they're still using this in the hospital, and it's approved, FDA approved for use in retinal angiography. If you look at literature, there are more than 200 papers already that have been reviewed on how ICG is being used as early as 2010 of this year. How does ICG work, or indocyanine green? So for the mechanism of action, let's look at the pharmacokinetic features of this this agent that we use for imaging the biliary tree. So what happens? It is injected intravenously, and the ICG, or indocyanine green, which is a tricarbocyanine type of dye or contrast medium, binds to the plasma proteins, and it is eventually distributed uniformly in the blood in the next 2 to 5 minutes. Once in the blood, this plasma, together with the ICG that binds to it, is taken up by the liver. And as it is taken up by the liver, it is secreted into the bile in the next 20 to 30 minutes. Therefore, knowing this mechanism, that means to say your ICG can fluoresce in the vascular system, and your ICG can fluoresce in the liver, and your ICG can also fluoresce in the bile. And we know bile outlines biliary anatomy. So your ICG binds to plasma, secreted into the bile. The concentration over time decreases exponentially. Nawawala siya eventually. It is excreted unmetabolized. It does not pass through the enterohepatic circulation. It is not excreted through the kidneys, and is safe with only some slight side effects. And sometimes this is mostly hypersensitivity, but it's very, very rare. Knowing the pharmacokinetics, we know it's useful for hepatic and circulatory function, tissue circulation perfusion, when you want to anastomose bowel and you want to check if the perfusion is good and not just by eyeballing it. There is ICG fluorescence there, and that means there's good perfusion. Then you're comfortable that you won't get a leak, most likely. And it outlines the biliary anatomy as well. It is used in many other surgeries and also other conditions like lymphography, neurosurgery, vascular surgery, reconstructive microsurgery, kidney transplant. Dr. Panias mentioned parathyroid surgery in identifying parathyroids, as well as in adrenal surgery and liver resection for tumors. This has been very useful and being used by our hepatobiliary surgeons. So ICG fluoresces, as we know, at near infrared range of around 800 nanometers. And it fluoresces as well through pigment, bile, plasma, lipid, and blood. So this is how ICG works. Fluorescent imaging using ICG cannot be seen with ordinary white light we use in laparoscopic surgery. This is what was happened several years before, which changes now, which I will explain later on. And then we can, to be able to visualize near infrared wavelength at 800 nanometers, a special device emitting a light that stimulates the ICG molecules is needed. So it works, it will appear this way in a grayscale, wherein your ICG for this particular equipment is color green. No? On the lower corner above, upper corner, picture in picture is the white light, and there's no ICG that can be seen using the old system. But using the ICG on grayscale, you could see fluorescence on grayscale. You could see this liver lighting up as green, and you also see the bile, the biliary anatomy lighting up as green as well. You could see that perfectly here. And you see the gallbladder lighting up as green, which means to say that ICG has already flowed into the gallbladder. How is ICG given? Well, practically ICG is given intravenously. And based on this brochure from the company that produces ICG, they recommend administering it for 30 minutes prior to a surgery, but we will go into that later on when I show you studies that we have done on our own. And we administer usually 2.5 milligrams of ICG solution that is prepared. No, I believe one vial contains around 25 milligrams. So we just give 2.5 milligrams of that diluted solution. And administer 2.5 milligrams of prepared ICG solution immediately before near-infrared imaging of vessels, blood flow, and related tissue perfusion. Meaning to say, if I want to see blood flow to a particular organ, I inject it now. In 2 to 5 minutes, I will see that blood vessel fluoresce because there's ICG there in 2 to 5 minutes because it binds to the plasma protein. But if I want to see it in the biliary anatomy, I have to wait at least 30 minutes for that to be up to that, so that uptake will be in the liver. So how is ICG fluorescence visualized by the naked eye? So this is how it is visualized by the naked eye during for white light. No, a source of near infrared light emits an excitation wave directed towards the ICG field biliary tree, and you need special equipment for this. ICG, which is bound to protein, is excited. This causes emission. So it is excitation and emission. This causes emission of a longer wavelength. And there is a filter as well, which removes unwanted shorter wavelengths in the instrument or equipment or the scope that we have. Then this image captured by the scope fluorescing the biliary tree is formed on the CCD camera scope, and it is processed for viewing in the monitor. And that is why when we see that, it is transmitted to the monitor through excitatory and emission, fluorescing the ICG through special equipments and filters and the special light, and we have that coming out in the monitor, which I'll show you some videos later on. So what happens in the ICG timeline is first, ICG is injected into the vein. Once it is injected, it travels through the blood, removed by the liver, secreted into the bile, and after ICG is secreted, it becomes visible in the extrahepatic biliary anatomy. The gallbladder now and biliary anatomy can be visualized when you convert it to a mode known as the ENV mode or near infrared vision mode. And the light source emits a near infrared light that excites the ICG. And you can now see this in the monitor. And it will appear as this. So if you look at this particular patient with using the ENV mode or near infrared vision mode in a green on a grayscale, you would see this, that the liver is fluoresced, the gallbladder is fluoresced, the biliary anatomy, there's the common bile duct being pointed by the suction tip, as well as the cystic duct that you can see here. So this is how we used to do the ICG in laparoscopic cholecystectomy, and you can easily switch from the infrared, the ENV mode to the white light mode, and this is how you see in the white light mode. So you don't see the ICG, at least in the old system. We did a study and presented this as basically our initial experience with the use of ICG, 9 lap colic procedures in 2 weeks. And patients were given 2.5 milligrams of ICG, and we do a skin test before we do that, and we identified using the fluorescence imaging. And these are the actual photographs that we got. You can see the liver there, very fluoresced with ICG, color green. And this was given around 1 hour, maybe 30 minutes at the time of induction. No? And you see that most of the fluorescence is from the liver, and there's little fluorescence in the biliary anatomy at 30 minutes. But you can still see an outline. So this was the initial experience we had. So when we would do the procedure, and you can see it here. So this is a laparoscopic cholecystectomy procedure, our actual case that we performed. And we convert ENV and white light, toggle it between the two. ENV to visualize the ICG, exciting the image is reflected, and the white light in the ordinary white light. So what we can see here in this particular video, similar to the initial video, we have the critical view of safety, and we now identify in ICG the common bile duct as well as the gallbladder. Now, we injected another 2.5 milligrams of ICG, and then what we wanted to do here is test if that vascular supply, which is the cystic artery, would fluoresce. So at this point, reinfusion of ICG, 0 minutes. Okay, and you will see this, that is the cystic artery, and we expect in 2 minutes that cystic artery should be green. What is the significance of this? In 2 to 5 minutes, that should be green. What is the significance of this? So any structure that lights up in two minutes or less, no, or even up to 5 minutes, is a vascular, is an arterial vessel. And here now we can see that that is the main blood supply of the gallbladder, which this was just during the experience, how the ICG would is applicable. What we see is we see the cystic. The speculation you can see is that the cystic duct is fluoresced and the gallbladder is fluorescent. What does that mean? It simply means one thing. There is no obstruction in the cystic duct because you see ICG in the gallbladder. And if there is no obstruction in the cystic duct, that tells us that there is no stone in the cystic duct. Then we can safely clip and cut that structure. So at 5 minutes, you now see the ICG in the cystic artery. More clear. There it is. And then it will be washed out later on. Okay, so vascular and biliary anatomy can also be determined. So what is the evidence on the use of ICG in the biliary anatomy and prevention of bile duct injury? Well, the first published study was in 2010 by Ishizawa. He's been giving a lot of lectures. If you have the opportunity to listen to him, it's very good because he was one of the first to use this. And on his 52 patients, 2.5 milligrams ICG injected 30 minutes following intubation. And what did he find out? Fluorescent imaging using ICG delineated the cystic duct in 52 patients. Cystic duct common hepatic duct junction was visualized in 50 patients out of 52. And he identified accessory ducts in 8 patients. But sometimes we cannot identify during our surgery, and we will be able to identify it only later on when it is transected. The conclusion given by Ishizawa was that fluorescent cholangiography identifies real-time identification of the biliary tree during dissection of the triangle of Calot. It may eventually be applied as a standard practice in avoiding bile duct injury. This is early 2010, and may eventually replace IOC. So there are many studies now comparing ICG and IOC. IOC is still the gold standard today. In another study later on in 2017, published in the Surgical Endoscopy by Black et al., systematic review of 19 studies. Cystic duct visualization using near-infrared imaging was seen 86 prior to dissection and 96.5% after dissection of the triangle of Calot. That's a very high figure for identifying the cystic duct. And also observed that the cystic duct was more frequently visualized using near-infrared imaging compared to the IOC. So the conclusion is that there are equal results of cystic duct and extrahepatic duct visualization comparing ICG and IOC. You have the same. And near-infrared imaging with ICG now, as their conclusion, may probably replace intraopcolangiogram in biliary tree mapping. Okay, so if the ICG can mimic the results of what we see in the IOC as far as biliary tree mapping is concerned, then maybe the ICG can replace as far as mapping of the anatomy is concerned. You have no skill needed because you don't have to do a cholangiogram. You don't need an entire team to perform it. You don't need the X-ray going up, or you don't need a portable X-ray or a C-arm, and the team is not exposed to radiation. if your main objective is just to visualize the anatomy. And if you look at the detection rates of extrahepatic biliary duct structures using ICG, maganda ang kanilang pick-up rate in identifying cystic duct, common hepatic duct, as well as later on you will see the common bile duct. Okay, so here, in terms of the procedure, there's a significant difference. It is longer to use an IOC than an ICG. Significant difference. If you look at identification of the common hepatic duct and the cystic duct and common hepatic junction, there is no difference between the ICG and the IOC. If you look at identification of the common bile duct, comparing ICG and IOC, no significant difference. Both can identify the common bile duct very well. If you look at the cystic duct, there is difference, significant difference. Your ICG can identify the cystic duct better than your IOC, based at least on this study. And if you look at identifying of the right and left hepatic duct, there is a significant difference in terms that the IOC is better. If you look at the intrahepatic, normally what we want to identify is the extrahepatic biliary tree when you do lab chole. So this is a very important table and analysis with comparing IOC and ICG. If there is no significant difference in identifying the common bile duct between ICG and IOC, then probably having an ICG capable equipment or machine or using this during your gallbladder surgeries might be more prudent in the sense that there's less time involved, less people involved, no skill at all in performing the IOC needed. You can do this, no X-ray needed, and no exposure to radiation. So when is the best time to give it? So we went ahead and did another study on these patients, and we gave them, divided them into 3 groups. One group was to give it to them 12 to 14 hours, another group 6 to 8 hours, another group 30 to 60 minutes. So we did this at Siemens Hospital, around 41 patients. I believe was included in this study. We gave 2.5 milligrams of indocyanine green. And the reason for this, because when you look at literature, there are several studies that were done telling us about the optimum treatment or the optimum timing of indocyanine green. Like for this paper by Chuchui, 15 hours was the ideal time for them. And for the paper of Bugard et al., the clinical trial demonstrated that the highest bile duct to liver ratio was achieved in 3 to 7 hours after 5 milligrams. So kanila 3 to 7 hours with 5 milligrams. And there were many other numerous studies done giving ICG 1 hour to a few minutes pre-op. Okay, so iba-iba on the best timing as far as gallbladder surgery is concerned. So we went back to the hospital, we did our series, our cases, and tried to divide them into 3 groups again. And first group, 12 to 14 hours, this is what we saw. Before dissection, you could see the biliary tree, the gallbladder, very well at 12 to 14 hours pre-op. And then the ICG was given 12 to 14 hours pre-op. And we took some pictures before dissection, during dissection, and after dissection. This is what we saw. Then we look at the ICG when given 6 to 8 hours. You see more prominent fluorescence in the biliary anatomy, not so much in the liver. And before dissection, during dissection, and even after dissection. And then we gave the ICG 30 to 60 minutes pre-op before induction. So this is what or at induction, practically, at induction. And we saw that most of the ICG fluoresced in the liver, mas marami, not much in the biliary tree, although in some cases, the biliary tree was imaged with ICG, but faintly compared to the liver, which has the most ICG there, and sometimes it can be difficult. So these are all patients 18 years old and above. This is our exclusion criteria in this particular data. Total number of 41 patients divided into 3 groups. 12 to 14 hour had 11 patients, 6 to 8 hours had 11 patients, and 30 to 60 minute group had 19 patients. This is the time that we gave the ICG prior to surgery. And we found out that, at least in our experience, 12 to 14 hours, what did we find out? Minimal to no visualization of liver parenchyma uh, in what we gave. Minimal visualization of the biliary tree. In 6 to 8 hours, moderate enhancement of the liver, biliary tree is visualized. And 30 to 60 minutes, liver parenchyma is highlighted very much. There's minimal visualization of the biliary tree, but can still be seen for this. So based on this study, and we could give it 30 to 60 minutes, at least for gallbladder surgery, and 6 to 8 hours. Works for us, at least from our data of only 41 patients. So it could be a promising alternative to intra-op cholangiogram, our ICG, because it helps us identify the biliary tree. It promotes safe surgery. We know where the common bile duct is. We know how to stay away from it. It identifies it very well. And also we know if there's stone in the cystic duct, because the gallbladder will not fluoresce if there's an obstruction in the cystic duct. And it is not surgeon dependent. Even a surgeon who is not comfortable in doing IOC during lap chole may opt to use the ICG to visualize the biliary tree as far as anatomy is concerned. So what is new in ICG? Fluorescence imaging, this is what is new. I will not touch much on this, but you will see up about the video ICG fluorescence overlaid in real time. And the ICG below, ICG fluorescence overlaid in real time on a grayscale mode. Sa taas, white light mode. The difference, you can see, and if you look at this video, which I borrowed from Anna from Stryker, and here is a gallbladder surgery. It is being performed using white light, the usual light that we use. This is the normal light. This patient has already been injected with ICG. And the difference nowadays is you can visualize in real time on a white light image. You don't have to shift from a grayscale to a normal scale or a white light scale. See, you have the colored features of the white light and still identify the biliary anatomy. And that is really something as far as advancement in technology is concerned. Imagine doing your laparoscopic gallbladder surgery and you see the biliary anatomy outlined as green because of the ICG. And you can continue performing your surgery and you directly visualize the biliary tree. So ladies and gentlemen, in conclusion, for laparoscopic cholecystectomy, there are several risk reduction strategies in preventing bile duct injury, namely identification of the landmarks, what we teach, the critical view of safety. You can do intra-op cholangiogram, bailout procedures, and conversion to open. But we should also consider ICG, a new modality, a modern modality, as an alternative imaging procedure, which can be useful in identifying the biliary anatomy without the radiation exposure to mitigate the risk of bile duct injury. Thank you very much for your kind attention.
Thank you very much, Dr. Mendoza, for a very informative lecture and very interesting that that we learned many from this lecture, that we can manipulate the timing of giving the ICG. So it depends on what procedure are we going to do based on the timing, injection timing of the ICG. So again, thank you very much. So for the other participants, do you have any questions to our lecturer, Dr. Mendoza? Sir, how much is the ICG, sir? May available lang ba sa ano yan, saan available lang po, sir, yung ICG, sir? Tsaka how much po?
Good question. And the ICG is available in the country, and this is free plugging. The ICG, we get it from our source is Mr. Kim. So far, I don't know if you know Mr. Kim is the Korean who supplies the ICG. And it costs, I think, if I'm not mistaken, before 6,000, I believe, if I'm not mistaken, per bottle. And that is the cost of the ICG.
Okay, Mr. Kim.
6,000.
Mr. Kim. Mr. Kim. So if I have a what I do, ano na?
When you open the bottle, kasi di ba parang 2.5 cc ba o 2.5 milligrams lang ang gagamitin. So
Correct.
may matitira pa doon.
Marami pa.
Just like the usual dye that we use when we perform IOC, yun ba, no? Once you open the bottle, pwedeng i-preserve, pwedeng gamitin uli hanggang sa maubos?
Well, ang recommendation is hindi. But what we do now is yung mga pasyente na lap cole, sabay-sabay, dun gagamitin na namin for these patients. But if you're going to, I think that there's no recommendation that you can open it, store it, and then use it again. I'm not sure about that. So if you have several lap coles in the hospital, you can just get from that bottle and inject to the patients IV. And then after that, discard it.
Siguro maganda after opening it, tapos the next day, kung may gagawing lap cole, pwedeng testingin kung kung it will still lighten up.
Yeah. Maybe the company will be in a better position to give the recommendation regarding
Kasi
that.
di ba, like in our institution, yung isang bote ng na ginagamit namin sa IOC, itinatago lang na residente yon, tapos they can use it hanggang sa maubos, hanggang sa ilang araw eh. And we've been doing that even during our residency.
Correct. It's
So,
one way
may
of
question
saving.
ako. This is regarding yung comparison between IOC and ICG. Sa IOC kasi you can demonstrate feeling defects, So nagagawa rin ba 'yun sa ICG?
That is the limitation of the ICG when it comes to trying to find out for stones in the common bile duct. So that's one limitation. So I don't think it is useful in determining the presence of stones in the common bile duct.
Kasi di ba when we do the IOC, di kukunan mo ng litrato, you see a feeling defect, then you do the usual CBD exploration, traction, and flashing. Tapos you take another shot doon sa IOC. Tapos kung mawala na yung feeling defect, then you will be medyo confident na you have cleared the common bile duct. So can that be also done using the ICG?
Clearance of the common bile duct, I don't think will be applicable for the ICG. Kasi hindi mo makikita kung walang feeling defect ba para ma-establish mo na clear siya. If it is in the distal CBD, kung may natirang stone doon, hindi mo masabi kung merong stone in the common bile duct. It is more useful for as far as anatomy is concerned, the biliary tree, rather than determining stones in the bile duct, at least in the distal common bile duct. Ang useful napansin ko in several cases that I've done is the presence of a stone in the cystic duct. Kasi makikita mo yung ICG nag-cut off at the cystic duct, and then there is no fluorescence of the gallbladder. And you will say, may bato to sa cystic duct kasi hindi pumunta yung ICG into the gallbladder. Then you suspect, then you open that, you cut that cystic duct and try to milk out the structure, if there's any stone there. Pero for common bile duct, I'm not sure if it's useful. I don't think it is. It cannot be done. So if you suspect a stone in the common bile duct, I think it's still best to go for the standard, which is the IOC.
Okay.
Sir, thank you, sir. We have several questions at the group chat, sir. One question here is from Dr. Elmer Reyes. Do you do routinely of the ICG during laparoscopic cholecystectomy, or selectively? You're just doing it selectively or routinely?
Right now, I'm doing it selectively. When I was doing the study, we were doing it routinely. in all cases, no, selected cases, pero routinely siya in all cholecystectomy cases. The limitation of the ICG is that when you have patients who's very thick tissues around the bile duct, no, makapal, fibrosis, scarred, sometimes you cannot see the fluorescence in that area. I'm not sure with the new SPY overlay on a white light image if it will be more useful for that. Where you have thick tissues, but now selectively. And one thing I'd like to share is that before I've been doing laparoscopic cholecystectomy for more than 20 years now, and I wasn't using ICG. So when I was doing this, when it was introduced to me, I was really skeptical. Sabi ko, hindi ko naman kailangan niya kasi 20 years na ako nag-lap ko, I'm comfortable with it and so on. But I realized later on, ang sarap pala na you actually have a blueprint of the anatomy of the biliary tree and you do your lap chole, parang iba yung, you have a better grasp of your confidence level in performing. And sure ka na wala kang na-transect na minor duct, sure ka na walang nagli-leak na bile from the liver bed, sure ka na kasi you see that fluorescent pag may nagli-leak na bile, and sure ka na you see the biliary anatomy.
Okay. Thank you, sir. There are several questions here regarding the are there any hypersensitivity reaction of the ICG? Or if there is, are there any antidote? Or also, what is the maximum dosage that we can use the ICG if it turns out na hindi siya mag-ilaw daw? That's
Well,
one of the questions.
The number one that is at least reported, although it's very rare, is hypersensitivity. And when we were starting, because of this, we would do skin tests for our ICGs and our patients. But if you talk to other surgeons, there's mixed ideas about this, and some saying that since it's really, really very rare, they don't even do any skin test anymore. The antidote is probably any antihistamine that you can give these patients, or your epinephrines if really in a bad worse situation. And maximum dose, I'm not sure about that, but I've tried as high as 5 milligrams for my gallbladder surgeries. I think even higher can be given. Maybe
okay, thank you,
somebody
sir.
who has experience with it. Those who use it in liver surgery probably use higher doses. Initial, alam ko initial they use 5 milligrams and they inject more probably after if needed.
Okay. Thank you, sir. Siguro mga 2 or 3 questions na lang i-cater natin. So, next question, sir, is this still useful for severe cholecystitis? Baka he means here for severe inflammation. Is ICG recommendable also? Or you decide for subtotal na lang, or you still forgo with the dissecting the critical view of safety in case
Good.
of a severe inflammation in that area?
Yeah. Very good question. In when in cases wherein you are going to do surgery on a patient who is diagnosed with acute cholecystitis, or on ultrasound you see there's thickened gallbladder wall, and also on ultrasound there is pericholecystic fluid, and you are considering that, oh, this is acute and chronic. I think giving this patient ICG is still helpful in a sense that it may help you intra-op, no? In identifying the biliary anatomy. Although it is not guaranteed, because the limitation is that if you have very thick fibrous tissue or very edematous tissue and above the hepatoduodenal ligament, then you may not be able to see the biliary tree at all, because it will mask the fluorescence of the ICG. And even if you see the biliary anatomy and you have an area that is thick and inflamed and adherent in the triangle of Calot, no, I will still not attempt to try to take that gallbladder out away of that triangle of Calot or its dense adhesion to the biliary tree. I will still go for that subtotal. Only if I have a good plane will I attempt it with ICG. Pero kung ang plane ko is fused, fibrosed, even if I see the biliary anatomy, I'll probably will not. Just tell me hanggang anong extent ang aking dissection. That is the thing that will be useful for me. But I will not attempt to try to take that gallbladder away from that biliary tree.
Okay. Thank you, sir. Thank you, sir. Sir, last another question, sir. Regarding you said that there's a lot of variation with the cystic anatomy, sir.
Mm-mm.
So, with that variations alone, sir, safe pa din ba, sir, talaga ang critical view of safety? Kasi sometimes, di ba, marami siyang variations eh. So, is it true to all variations exposing the critical view of safety?
Yes, for me, I believe that the more it should be exposed because of those variations. Because if you do not expose the critical view of safety, then you might mistake the common bile duct as the cystic duct. And the more it should be with these variations that you identify a structure that is separate from the common bile duct. Whether that cystic duct enters directly into the common bile duct, whether it enters low into the common bile duct, up into the common bile duct, around the common bile duct, to the left of the common bile duct, you still have to identify the artery, you still have to identify the cystic plate, and at least identify this ductal structure, which is the cystic duct at the infundibulocystic junction area at least.
Okay. Thank you, sir. Sir, last question, sir, regarding the 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 duck of Lushka. If you
Mm-mm.
encounter such duck of Lushka, do you just ligate it, or kasi this is one of the questions in our meetings in this
Mm-mm.
department regarding the duck of
Mm-mm.
Lushka. Do you just ligate it, or some questions, do you repair it, or
Mm-mm.
do you put dye on it, or what do you do, sir, if you
Mm-mm.
encounter such?
Okay, so that's a very good question, and we've encountered that duck. We don't know if it's a duck of Lushkat na totoo, but there's a leaking bile in a lumen that we see at the bed of the gallbladder, cystic plate. What I do is, when you see that, it's either you see bile flowing out, right? O kaya when you're done with your surgery, you take out the gallbladder, you put your gauze inside, which I do to check, especially in difficult gallbladders. I put my gauze there, I pack it in the area, I pull it out and see if I see a yellow stain. Kung meron, something's leaking there, and then I look for it. And if I see it, I suture ligate it. That leak, I suture ligate it. Provided that I know that it's not a any other anomalous duct except it's a duct of Lushka in the riverbed. Now the one thing with ICG, in a leaking duct, whether it's a Lushka or any, you see green flowing out, fluoresce in green. You can see it really flowing. And if it's in the liver bed, I just simply suture ligate. Figure of
Okay.
eight.
Thank you, sir. Thank you, sir. I think last question na to, sir. Is ICG safe in pregnant patients? Have you tried it?
Yan ang mahirap na tanong. Kasi wala pa akong encounter na pregnant patient. That is a question that has been asked many times. Well, that's something I have to find out. I'm not sure. I haven't used it for pregnant. I'm very worried when I do pregnant patients in what I give these patients. So if I have a pregnant patient and I need to do ICG, I probably won't do ICG yet. I don't have any evidence that is good enough to tell me that it is safe. Unlike probably is, maybe, I don't know, but I'll be worried in using anything in pregnant patients at this point, unless there's really good evidence that it is safe. I don't know the answer to that, but not like let's take an analogy. Before they said that laparoscopic cholecystectomy is not safe for pregnant patients in the first trimester, and it's only recommended in the second and third. Now, data shows there's evidence already that it is safe even for first trimester patients. So that's something probably that will evolve.
RJ, marami pang tanong sa chat box ha.
Okay. Eunice, can you help me? Sorry na-lag out ako eh. So yung other questions siguro pakibasa na lang. Eunice, can you help me out?
A question from Dr. Geoffrey Cuvin. Do you recommend using ICG during the learning curve of laparoscopic cholecystectomy, or do we still go for careful patient selection first?
Okay, with regard to that question, during residency training, I think you should be trained in how to do an IOC. That's one thing for sure. That is still the gold standard. Because you might be going to areas where you don't have an ICG and you need to see that biliary tree, or you need to identify stone in the gallbladder, in the common bile duct. You have to learn how to perform IOC during lap chole. That is mandatory for everybody who's doing lap chole in this day and age. ICG is a supplement that you may use in your practice. But in your training, you have to learn the skills on how to perform an IOC.
Thank you, sir.
That's what I believe, yeah.
Sir, did you encounter, sir, other researches daw, sir, that proves that is the use of ICG in lab cole can decrease bile duct injury, sir?
Well, it can mitigate the risk of bile duct injury by identifying it. That is what we can say about ICG. But evidence to show that it really decreases the incidence of bile duct injury to what we have now, I don't have any strong evidence regarding that. But in theory, the theoretical risk of injuring the bile duct is probably theoretically lower if you identify, if you can see the anatomy. Because the most common cause of injury to the bile duct is visual perception illusion, thinking that the common bile duct is the cystic duct. So it's a modality that can mitigate the risk.
Thank you, sir.
Thank you, sir.
We have another question from our PGI Moredo. Are there any contraindications like other comorbids in the use of ICG daw po?
None that I know of. None that I, except hypersensitivity to the drug.
Thank you, sir. And then another question from one of our residents. What will be the impact of ICG guided lap chole in the training of the residents? And should ICG be the future for all lap chole cases?
Well, what will be the impact of ICG on the training of the residents? Well, if you just use ICG all the time and you don't use the IOC, the intraoptical angiogram, then you will not develop the skills needed to perform an IOC in the event that you need to check if there are stones in the bile duct. Simply because ICG will not help you determine the presence of stones in the bile duct. It will give you the anatomy. But to show filling defects, like Dr. Alex Palines mentioned, that may be the limitation of ICG, absolute limitation. So you still have to learn how to do IOC. Okay.
Thank you, sir.
Okay, I think that's it, sir. If other so this last chance na sa other participants, please raise your questions or just unmute your mic kung may hindi kami na cater na question. So if there is none, thank you again. Thank you very much again, Dr. Mendoza, for a very fruitful lecture. Eunice, I think we will award a certificate. Eunice?
Sir, yung next speaker po muna.
Speaker muna. Okay, sir.
Okay. Thank you very much. Thank you, everyone. Thank you.
Thank you, Dr. Mendoza. We'll just send your certificate for your lecture. Thank you very much.
I will, yeah. I'll be staying. I'll be listening to the next speaker as well. Thank you.
Thank you, Dr. Ike.
Thank you, sir.
Thank you, Aldrin.
So for our second speaker, we have a senior communication specialist from the Striker East Asia, Hanoi, Vietnam, who will enlighten us about the integrated operating room setup for improved efficiency. Let us all welcome Mr. Jordan R. Noble.
Thank you for
Mr.
having me.
Noble, and you can screenshot and you can share your screen now. Thank you.
Okay. Okay, can everyone see my screen and hear my audio?
Sorry, we cannot see your screen yet. But we can hear you clearly.
Okay, so I have audio.
Yeah, you have the audio.
Okay. See if anything's coming through.
Okay, we can see your lecture now.
All right, there we go. Apologize for that delay. So I'm gonna go ahead and say thanks to everyone who has stayed on for this second portion of the call. I'd like to say thank you to everyone in the team from Batangas, and also I wanted to give a thank you to Transmedic for partnering with Stryker to be able to continue to be able to contribute to this series. So as you just heard in the introduction a little bit earlier, my name is Jordan Noble. I'm a senior communications specialist. I'm currently based in Hanoi, Vietnam, and my role here in the ASEAN region is to serve as a regional expert for the Stryker iSuite and the Stryker Communications business. And in today's presentation, we're going to go through the Stryker iSuite, what exactly it is, talk about the integrated operating room and what this setup consists of, and ultimately get an understanding of what this solution is and how it can provide benefit to your team and create the best integrated OR experience for your specialties. So at Stryker, every presentation begins with our mission statement, which is, together with our customers, we are driven to help make healthcare better. We do this to continually remind us that we come together in today's challenging healthcare environment to provide our customers with the solutions that they need to improve quality, efficiency, and patient experiences. We understand that these challenges ultimately create opportunities for us to make healthcare better, and for our customers and for the patients that they serve. Our core values of integrity, accountability, people, and performance guide our behaviors and our actions. And we do what's right, we do what we say, we grow talent, and we deliver. In this slide, we've identified your mission statement, the leading multi-specialty institution working towards a healthy caliber zone, and we've reviewed ours at Stryker. We also understand that having similar aligned goals is critical when it comes to building a partnership. And as you can see here, improving patient care is extremely important to both of our organizations. So at Stryker, how are we a different partner in this effort to make healthcare better? Stryker has a unique standing in the medical technology market. We offer an extensive portfolio of product and services based on more than 75 years of innovation, with solutions ranging from orthopedic implants to robotics to integrated operating rooms. This depth allows us to work with your specialized and customized situations to provide a solution for every type of project. No other infrastructure and integration vendor on the market has these resources and specialty experiences to truly understand your clinical needs. So with such a diverse portfolio, as mentioned, over 60,000 products across the entire business, at Stryker, we're organized into divisions to maintain a focus in our related businesses. At Stryker Communications in particularly, we have over 750 employees that focus just on the iSuite itself. And the iSuite is our customized, efficient, seamlessly integrated operating room. We're dedicated to building world-class products to equip and connect your surgical suites. We build our products in 2 primary locations. We have a US headquarters office in Dallas, Texas, and our international headquarters is in Tuttlingen, Germany. Our global teams and hundreds of field-based employees make it possible for us to install numerous operating suites each month. In addition, we have dedicated support teams to ensure that you're taken care well after your installation. So what is Stryker Communications? As mentioned in the previous slide, we build world-class operating rooms that are designed to integrate data, video, and workflows while driving patient experience. In doing so, we promise to help you achieve your specific goals for communication, workflow, and the growth in your operating rooms. Stryker's iSuite delivers on this commitment by creating opportunities for improved OR efficiencies and ultimately by enabling the best experience for you and for your patients. By doing that and keeping to our promise, we ultimately create the best integrated OR experience. The iSuite is your customized, efficient, seamlessly integrated operating room. From the tip of the endoscope to the EMR, Stryker can provide you with the complete solution. We equip your room with world-class equipment and connect your operating suite to the world. We're not a vendor that only provides booms and lights or that just provides video integration or just endoscopy equipment. We're the only company that can provide it all, giving you the confidence, the peace of mind that all the parts of your surgical suite have been designed to work together flawlessly. With our team of dedicated professionals, we will help you completely transform your OR. An integrated ecosystem of Stryker infrastructure and integration is designed to increase workflow efficiencies while providing a safe space for the clinician to work. As previously highlighted in our mission statement, our goal is ultimately to make healthcare better. This includes helping you provide more efficient patient care while saving the hospital money and increasing staff safety. A better operating environment for clinicians is designed to improve patient outcomes. These statistics come from a 2015 white paper where we quantified the impact of a fully integrated iSuite on multiple different metrics. This shows that the iSuite is more efficient between cases, during cases, all while reducing workplace injuries for your staff. So why is Stryker the right team to work with? In part because of our experience and our track record of delivering results. This chart shows the list of the US News Honor Roll for the best hospitals of 2019 and 2020. Each check mark shows where Stryker equipment is installed in each of our primary product categories for iSuite. These primary product categories include booms and lights, video integration, surgical tables, video, and SPY, which also includes endoscopy equipment. When the iSuite's individually broken down into its sub-brands, the iSuite really starts at the core of any operating room, and that's the surgical table. Our surgical tables have best-in-class features, including not only a minimum low height, but an extreme range of heights that can be 1,250 pounds of weight capacity, superior imaging access, and they're also engineered for patients and staff in mind. So these include the option to have stainless steel base covers, which can help with turnover and infection control purposes, the ability to have carbon fiber tabletops to aid with imaging, intraoperative imaging, and self-propelled drive systems that can help move these tables out of the room much easier. And along with these, there's a huge complete line of accessories that can be adjusted and configured based on the needs of your own facility and your specialties. Being able to visualize during surgery is extremely important, and this is done through our monitor systems and our lighting in the iSuite. For monitors, this is done using the universal display mount. It's the only display mount on the market that allows your surgical displays to be rotated up to 540 degrees. They come 4K ready, and they can also be rotated and stowed away when they're not in the OR to save space. And they also have protective shields that cover the cabling that provide a smooth, cleanable surface on them. Our surgical lights have numerous superior technology that aid with shadow reduction. The LED technology allows for over 35,000 hours between light bulb changes, and they have a maximum depth of field to eliminate any repositioning that may be unnecessarily avoidable during surgery. Some of the configurations include sterile control, different color temperature, and ambient lighting features as well that can be used during MIS cases. Another important component of the iSuite itself is equipment management. Whether you prefer to call these booms, pendants, Stryker booms and pendants are designed around two really important critical elements, being that they're easy to use and easy to move. Extensive mounting options for optimal room design make them easy to use. There's a wide range of suspension configurations to help sure that they actually fit in your OR. Over 400 accessories are available, and these do have the option to have complete configurability at the service head. And they're also really easy to move. So they're future ready and intuitive user controls, feature capacitive touch technology with an instant brake release. And these electric brakes that they are equipped with are quiet, effortless, and they also have long-term reliability built into them. We can't talk about an iSuite without talking about integration. And at Stryker, the connected OR IP is the future of integration. It provides a future-ready OR with 4K video routing. It has upgradable and open architecture that has plug-and-play functionality. It delivers clinical value with uncompressed video, connected device control, and significant possibilities for the future. Multiple install options are also available, including a zero footprint, optional installation, remote installation, that's all customizable based on the needs of your unique project. All of this is centralized and driven through the connected OR hub. The hub enables 4K today and in the future. It creates a simplified user experience for staff in some of the most complex clinical environment and drives clinical value by creating a streamlined workflow around fluorescence. As Stryker's integrated operating room offerings transform into the future, functionality of the connected OR hub will continue to grow and provide clinical value for our customers for many years to come. Stryker iSuite also makes live video possible. So whether you need to communicate with another OR for progress updates, verify lab results with pathology without having to leave the OR, participate in discussions with a remote campus, consult with specialists intraoperatively to facilitate patient care, broadcast live surgery off-site, or to educate students on the latest techniques through live Q&A sessions. Stryker and iSuite can make this happen. And we do this through real-time audio and video communication throughout the hospital and around the world. It's done in HD video, and it's easy to connect with your stored contacts, and also utilizes OR privacy. Once your case is complete, Stryker solutions help making sure that your data is centralized through our server-based storage solutions. Edit, archive, share. Make sure to store your surgical images, videos, and documents to a centralized platform with easy controlled user access. Edit content in an easy-to-use browser interface. Share videos and images with your patients. Refer physicians and colleagues. Protect patient information and drive HIPAA compliance if needed. By preventing the need for physicians to burn content to USB, DVD media, or print out any pictures taken during the case. Our OR renovation services are with you through every phase. Our comprehensive solution provides complete control of the renovation project and equipment installation. Working with Transmedic, we manage your patient care environment projects through every phase, from design concept to construction, all the way to renovation. Control your tomorrow by connecting today. Our integration solutions are future ready, whether it be connecting you and your OR to the 4K requirements of today, or allowing you future connections or the future connections and technologies of tomorrow. Thank you so much.
Thank you, Mr. Noble, for sharing your expertise to us. To other participants, do you have questions to Mr. Noble? Anyone? Any questions? So if there's none, thank you very much again, Mr. Noble. I think, Eunice, can we proceed with the giving of certificates? Sorry. There's another question here. Good evening from Dr. Elmo Reyes. This is a structural question. Minimum dimension of the theater, floor area, and height. He's asking about the floor area and the height or minimum dimension of the theater, Mr. Noble.
Yeah, so that's a good question, and a great early on design consideration to think about. As far as a minimum height, focusing on kind of the height first, typically right around 3 meters or 9 feet is average. If it is lower than that, it may be of concern, but we do have design tools that we could compile into some software to see what it would actually look like. And then floor area, it depends. The biggest thing is kind of getting an idea of what the space is intended to use for. But as far as minimal needs goes, it can be relatively small. We've integrated in spaces as small as ICU rooms before, using square foot, probably sometimes under 100 square feet. I don't know what that would convert to in square meters off the top of my head, but yeah, relatively small, and it can also be, and it can of course be large as well when you get into the scale of like a hybrid type theater.
There were
Okay, thank you,
questions?
sir.
Question?
Yes, sir, Dr. Mendoza.
Yes, hi. Good evening, Jordan, Noble.
Good evening.
Very good. Good evening. Very good presentation. We in our hospital we currently have a what do you call it? Endo suite with Striker, and it has an limited integration, and we were using the Sydney system. We're using the Sydney system, and to upgrade to the latest product or the latest model that you have, will there be a lot of changes from that, or do we just have to put in some new software? We have the PTZ, we have all the we have the 1588s now installed, and to upgrade to what we want as an integrated system, how do we go about that? Is it a total replacement or?
Yeah, good question. So it sounds like you have one of the most difficult things to start with is something that you already have, which is the infrastructure. So it sounds like you have all of the necessary pathways in place. So it would be a relatively simple upgrade to do. And it would be a combination of definitely upgrading the Sydney and getting you the latest hardware, the integration hardware that would also work with some of the software as well. So that's something, you know, we would just need a better understanding of what, you know, what the room is used for, what type of cases and procedures you'd like to use, and then yeah, we could go about it from there. Because it could be very simple, but it could also be large and extensive if needed. That's one of the major considerations and unique things about iSuite is that it's totally based on your space, your needs, and we're able to configure it based on what you'd like to get out of the room space.
Correct. So probably the option of just maintaining that room and starting with a new room could also be considered from ground up, right?
Yeah, absolutely. Yeah, whether it's a new construction or whether it's a renovation, yeah, both those options are available.
Thank you.
Yes, thank you.
Thank you again. Are there any questions from the participants? So I think again, thank you very much, Mr. Noble. Eunice, can we proceed to our program? So for the awarding of certificates.
Thank you for the very wonderful lecture. Let us now proceed to the awarding of the certificates.
So again, certificate of appreciation awarded to Miguel C. Mendoza, MD FPS, FXPS, FP for his invaluable support as a speaker in the online live lecture Flourescence Guided Surgery during the Surgery Month 2020, given this 25th day of September 2020. Thank you very much. And to me. And to Mr. Jordan Noble for his invaluable support as a speaker also in this live online live lecture on the Striker iSuite integrated operating room set up during the surgery month given this 25th day of September 2020. Mr. Noble, thank you very much again.
Like
Any yes?
to give this certificate of appreciation to Dr. Romero for his invaluable support as Flourescence guided surgery. And this day of cancer.
Okay, thank you. Thank you very much also to Transmedic. Dr. Palines, do you have any words? Dr. Francisco or Dr. Bergberabe?
Attendance.
Picture daw po for the attendance. Mr. Noble, please join us for picture taking.
May we request all of you to please turn on your video for a picture taking po. So, for the first page, 1, 2, 3. Okay, next page po. 1, 2, 3. Next page. 1, 2, 3.
Okay, wacky shot. Okay. Any more last words from our chairman or vice chairman and our training officer, Dr. Palines, Dr. Francisco, and Dr. Berberabe?
Si Sir na lang.
Sir.
Wala na. Thank you very much everyone for attending.
Salamat po, Dr. Ike.
Thank you. Salamat sa inyo.
See you on Monday, Ike.
Yes, sir. Dr. Alex, thank you.
Thanks,
Thank
Dr.
you, Kuya
Ike.
Alex. Kuya Roy.
Good job, Dr. RJ.
Salamat sa inyo.
Thank you, Mr. Noble.
Dr. Karaos, nakita ko.
Bye. Thank you, Doc Ike.
Ay, salamat. Thank you. Miss ko na pumunta dyan sa inyo.
Sige po. Ingat po kayo lahat.
Masaya dyan, masaya. Thank you, Dr. Romero.
Thank you, sir. Thank you, sir.
Galing. Very nice. Hanggang end of the month, Kuya Alex, ang surgery month?
Every September kami.
Oh.
Every September. Dati, July. Pinalipat ko na ng September para timing sa PCS sa yung surgery month.
I see.
Nagkagani-ganito nga eh. So, kami lang actually ang department na nag-celebrate ng month eh. Yung iba, hindi na tinuloy.
Kahit sa hospital namin, dapat April yung namin, hindi rin namin tinuloy na.
Hindi na tuloy.
Gulo-gulo pa eh. At least natuloy nito.
Hindi na rin namin. Actually, marami na mga activities. Kaya naman, naidaos din. Meron pa kaming natitirang until the end of the month. Pero may problema kasi yung Smart yata mag-upgrade nung kanilang submarine cable. Mawawala yung mga
dapat may mag-umpisa hanggang next week. Hanggang 30 ata or something.
Oo. Yun.
Pero I think minove nila for starting tomorrow. May announcement kanina o kagabi. Ayun. So, ingat kayo lahat dyan sa Batangas.
Thank you, Ay. Good night.
Ingat. Pero naglalap na pala kayo dyan sa Batangas? Nag-umpisa na kayo?
Nang?
Lap. Laparoscopy.
Thank you, Sir Ike.
Ay, thank you, Arvin.
Nag-i-start na sila.
Okay.
Mag-evacuator pa tayo? Wala eh.
Wala pa. Negative pressure.
Yun, meron. Negative pressure.
Galing.
So, may order na rin ng ang DOH that we can resume the elective cases. Lamang.
Central palang order. No?
Lahat ay lahat ng pasyente ay mandatory ni swab.
I see. Oo. Oo.
Lahat ng
Oo nga.
operahan.
Correct. Oo. Ako rin, lahat ng inopera ko, pinapaswab ko kasi hindi ka naman makakasiguro talaga. Hindi mo pa alam talaga.
Oo. Pero yung Asian sa pool, may negative pressure na yan even before the pandemic.
Ang merong negative pressure yung endoscopy room namin. So lahat ngayon ng COVID, ginawa sa endoscopy room.
Oh.
And then habang ginagawa doon, nag-convert ng 2 kwarto sa separate wing na OR into negative pressure. So umalis na kami ng endoscopy room, meron kaming 2 OR na separate sa main OR na naka-negative.
Kami yung old OR complex namin, yun ang pinaka-convert namin into negative pressure. Tapos itong bago, yung pinag-ooperahan ninyo, yung sa bago,
yan yung main.
Gagawan pa lang, may proposal na, gagawin lahat. Pero pagka may swab at negative, pwedeng sa taas gawin. Pero naka-full PPE pa rin ng mga residente.
Correct. Ganun din kami. Ganun din para makasiguro. Para makasiguro. Kasi nung araw ang attitude pag negative ang PCR mo, surgical mask pwede na, di ba? Pero hindi pala hindi pala siguro, hindi ka nakakasiguro pa rin.
Sabi nga sa PGH, the test is only as good as the time it was taken.
Oo nga, totoo. That is true.
Hindi ka na nakakasigurado.
Hindi ka nakakasiguro talaga. Kaya buti na yung safe na, di ba? Pati yung eyewear protective, no?
Among the departments, kami lang ang hindi pa tinatamaan. Residente or consultant.
Galing.
Pero yung yung pedia, OB, IM, lahat nadali na. Yung OB, nagsara pa nga for a couple of days. So maswerte pa rin kami. Matitibay yung mga residente ko.
Galing.
Oo, pagka hindi yata naliligo, tumatalsik yung
ganun ba yan?
Putelan.
Sabihin ko na rin sa mga residente ko, wag maligo. Ayun, sige, maraming salamat sa inyo. At ingat lang, kita tayo Monday kay Alex and sa lahat.
Thank you.
Thank you po.
Okay, salamat.
Again, thank you po, Dr. Mendoza. Thank you to our sponsors, Transmedic and Stryker, for supporting this event. Again, a pleasant evening to everyone. Thank you po.